Good morning, everyone, and welcome to the AI and Health Online Conference. We're so excited that you're joining us today. My name is Curt Langlotz. I'm Director of the Center for AI in Medicine and Imaging at Stanford and Associate Director of the Human-Centered AI Institute. Before we begin, I have some housekeeping announcements and some tips for navigating the conference portal. When you logged into the conference portal, you landed in our conference lobby. On the left-hand side, you can view our conference agenda and list of sessions. You can explore the navigation tabs to discover the other elements of the conference. In the center of the lobby page, you can browse announcements, social media posts, and photos from our photo booth. Lastly, on the right-hand side of the lobby, feel free to use the chat box to interact with other conference attendees. You can immerse yourself in the conference by creating a keepsake photo, claiming prizes from our conference game, networking with colleagues, or taking a live walking tour of Auckland or Prague during one of the breaks. Just navigate to these areas of the portal and enjoy. If you encounter any technical issues today, there are 3 ways to get support. First, you can click on the Help tab to get support from an instructional video on using the conference portal, or you can use the chatbot, which is a speech bubble at the bottom left of the conference portal to instant message with a conference staff member, or you can just email us at ai_healthconference@stanford.edu. Please join the conversation on social media by tagging Stanford CME, Stanford High, or Stanford AIMI on Twitter, LinkedIn, or Facebook. And don't forget to use the hashtag for today and tomorrow, Stanford AI Health. If you'd like to claim CME credits after the conference, be on the lookout for an email from us later this week with instructions on completing the evaluation, attesting to the number of hours you participated and claiming your credits. There are also instructions in the lobby announcements section. With that, I'd like to take about 5 minutes to give you some of the history of AI and health here at Stanford, which I think helps explain how Stanford can put on an event of this scope and scale. So I want to bring you back to the 1970s. So this is the ARPANET, which is the precursor of the internet. It was described at the time as a complex web of computer telephone links that spans the country from east to west. And one of my first email address ever was at sumxaim.arpa, which was on this ARPANET. So built on top of this ARPANET back then was something called the Stanford University Medical Experimental Computer for AI in Medicine, or SumXAIM. And I encourage you, this report is still online from 1980, March. It's a wonderful time capsule. It has some of these fantastic illustrations here of computers and physicians. Looks like they got the tape drive wrong, but they have the neural link right here. Really fun. Enjoyed the stethoscope there as well. But this was a national research resource funded by the National Institutes of Health here in the US, and was originally established by Ed Feigenbaum, who's a professor of computer science here now, emeritus professor, and Josh Lederberg, who'd won the Nobel Prize in Medicine in 1958, and was advised by Herb Simon, who was Ed Feigenbaum's advisor at Carnegie Tech and went on to win the Nobel Prize in the 70s. Ultimately, the leadership was passed on to Ted Shortliff, who many of you may know as one of the fathers of AI in medicine, who was a longtime faculty member here at Stanford. So I just wanted to review for you some of the things that are contained in this report, some of the accomplishments in AI in medicine that had been made as a part of this research resource, this network, that all of which was interconnected using the ARPANET. So the first of these, again, many of you may be familiar with this, MyCin, which was an expert system or an AI system. It was a rule-based system. You see one of the rules here at the bottom left was designed for the diagnosis and treatment of meningitis. And even back then, you can see here's a clinical evaluation where we're comparing the number of cases where therapy was rated as acceptable, whether it was MyCin or whether it was faculty or residents or students. You can see that the program was performing at a human level even back then. So that's one of the first decision support systems. And then another part of this SumXAIM network was ARAMIS, which was the American Rheumatology Association Medical Information System. This was connected institutions, dozens of them around the country, all of whom were contributing data about chronic disease, rheumatologic disease, to a single unified database. So this is an example, even back then, of multi-institutional data, real-world evidence. And lastly, here's a project called ConGen, Constrained Structure Generation. So you could pass a molecular formula, like here C15H26O, and the program would generate all of the possible chemical configurations. Here, 177 different structures were generated to help chemists determine the molecular structure of organic compounds. So this is sort of a great grand aunt of AlphaFold, I suppose. So it's interesting to see the parallels between the work then and the work today. So that's part of the long history of AI in health here at Stanford. And I just wanted to take a moment to look at the strengths that Stanford has today that enable us to thrive and lead in this area by the numbers. So interdisciplinary research is a hallmark of what we do here. We've awarded over $2 million in internal grants to our investigators here and have over 150 affiliated faculty from 20 departments across Stanford, all of whom are working in this area, and you'll see many of them today. Open science, so we've contributed 18 AI-ready clinical data sets to the public domain with code and models publicly released as well, and have partnered with the Gordon and Betty Moore Foundation to create an open AI data ecosystem plan. We have the infrastructure that has all of our clinical data in digital form, easily available for machine learning experiments. We have the first all-digital pathology department in the US and have a center of excellence in the multiplex cellular imaging at the microscopic level. And of course, we're here in Silicon Valley. We have relationships with 15 AI and health industry partners and have spun off 9 AI and health companies out of Stanford Labs since 2018. And then lastly, we're very interested in the policy and regulatory space. So we have authored 6 health policy briefs that are disseminated to staff on the Hill, in Congress, and other places where policymakers think about these things. And we have 3 active health policy projects here, one focusing on tort liability in AI, one on the dangers of dual use technologies in AI, AI technologies, and one supporting AI policy scholars. And then, of course, we share our campus with many of the world's foremost thinkers in fields like ethics, education, law, and philosophy. We have our healthcare enterprise, our Stanford Healthcare, which is right on campus, right across the street from the School of Medicine and the Engineering School, and public-private partnerships like those with the FDA. So that's our foundation. And really, we feel strongly that there are 4 pillars that are needed to have success in transforming healthcare with AI. One has to do with scientific discovery. So we have Nobel Prize-winning laboratories with expertise in genomics, computational sciences, laboratory sciences. And then we have expertise in the clinical decision-making applications and building AI to help clinicians make decisions on behalf of their patients. That's been the hallmark of the AIMI Center. Care delivery. So we have the healthcare delivery system, and we've invested in the infrastructure and team. Nigam Shah, our AIMI Center co-director, serves as the chief data scientist at Stanford Healthcare and is building out all of those capabilities for the ethical deployment of AI for our patients. And then, of course, our location here in Silicon Valley to be able to translate beyond our walls the innovations that happen here. So if you think about how would we transform human health in the era of AI, you need to run through all of these stages in various focus areas, whether it's imaging, my area as a radiologist, or cancer, pharmacology, cardiovascular. You can see these many areas, often multimodal data sets and work that bridges across areas. So Stanford is one of the very few institutions that has all the strengths that are needed to innovate in this area. And so we're excited about the opportunities here. With that, on behalf of the Stanford Institute for Human-Centered AI and the Center for AI in Medicine and Imaging, I want to take a moment to recognize our co-organizer for this event, the Stanford Center for Continuing Medical Education. which has led the effort to organize the logistics for this program. We're grateful for the partnerships that enabled us to organize a massive gathering of AI and health researchers. And special thanks to all the staff at AIMI, HI, and the CME office that made this event possible. With that, we're moments away from kicking off an incredible event that's reaching a global audience. So I would like to introduce our speaker and moderator for the next session. John Halamka is president of the Mayo Clinic Platform. He leads a portfolio of platform businesses focused on transforming healthcare by leveraging AI-connected healthcare devices and a network of trusted partners. Before his appointment at the Mayo Clinic, he was Chief Information Officer at Beth Israel Deaconess Medical Center and the International Healthcare Innovation Professor at Harvard Medical School, where he helped the George Bush administration, the Obama administration, and governments around the world plan their healthcare information strategies. Dr. Halamka completed his undergraduate studies here at Stanford, where I knew him and where we became acquainted. He earned his medical degree at the University of California, San Francisco, and pursued graduate work in bioengineering at UC Berkeley. He completed his residency at Harbor-UCLA Medical Center in the Department of Emergency Medicine and is a practicing emergency medicine physician. He was elected to the National Academy of Medicine in 2020. Dr. Halamka has written a dozen books about technology-related issues, hundreds of articles, and thousands of posts on the Geek Doctor blog. He and his wife also run Unity Farm Sanctuary in Sherborne, Massachusetts, the largest animal sanctuary in New England, which includes 300 animals, 30 acres of agricultural production, and a cidery. Hosting the fireside chat with Dr. Halamka will be Dr. Natalie Pagler. She's a board-certified pediatric intensivist and one of the first board-certified clinical informaticists. She's a clinical professor of pediatric critical care at Stanford University School of Medicine and the chief medical information officer at Stanford Children's Health, where she helped lead the organization to HIMSS Level 7 electronic medical record and analytics adoption, as well as a HIMSS Davies Award of Excellence. Dr. Pagler holds a master's degree in medical education, studying the impact of computerized clinical decision support tools on clinicians' knowledge, behaviors, and attitudes. She has spearheaded the development of Stanford Children's world-class digital health program, as well as multiple innovative computerized clinical decision support tools to enhance quality of care, efficiency, and patient safety. Dr. Pagler has also been active in shaping the curriculum for the emerging clinical informatics specialty. She's the program director and co-founder of Stanford Clinical Informatics Fellowship, the first ACGME accredited fellowships in clinical informatics. After the keynote presentation, Dr. Pagler will host a fireside chat with John. If you have any questions for the keynote, please add them to the tab adjacent to this stream, Slido, and Natalie will do her best to field the questions submitted. With that, I hope you'll take advantage of everything this conference has to offer. After the holidays, we'll have session recordings available for you to peruse and continue the learning in the new year. So welcome to day one of the Stanford AI and Health Online Conference. At this point, I'll hand the stage over to Dr. Halamka for his presentation. Take it away, John.
Well, Curt, thanks so much. And Curt and I were students together, late 70s, early 80s. I was a Sumex AIM user. I was a Myson user. I knew Ed Feigenbaum. I worked with Ted Shortliff. And of course, he and I have had decades of experience together. So isn't it interesting to see where we were and where we've gone? And let's reflect on that. So yesterday, I had an opportunity to spend an hour with Scott Cook, the founder of Intuit. And he asked me this intriguing question. He said, when you think about where AI was in the late 70s, early 80s, where did you expect it to be in 2022? And is it where you want it to be? Or are we still waiting for a major revolution? And what I told him is, we're actually at the cusp of a major revolution. And I don't mean 5 years from now. I mean in the next couple of quarters. And let me reflect a bit about why I think that's true. What are some of the things that all of us in this conference should be working on and what we're going to see? So I'm 60. Some of you are probably the care navigator for your family. You may help those with healthcare who are older, those who are younger. And I'll ask you the question, how easy is that? And this is not a reflection of Stanford or UC or Mayo or anybody, but I would argue care navigation in 2022 is hard. If you wake up with a sign or symptom, do you know where to go? With what urgency? Do you know what care you need, what journey you'll have, what potholes on that journey might occur? I think the answer is you don't, but you should. And we're pretty close to that. So if we were to enumerate the characteristics about our current healthcare system, again, just speaking about systems generally, not any one institution, many of these systems are disconnected. I'll call, labs, clinics, pharmacies, hospitals, not so much fully integrated end to end. We typically have diagnosis late. That means we have to have invasive, sometimes expensive or painful measures taken. Much of our care is sick care, not preventative care. It's not convenient. It's not easy to access, certainly not frictionless. So I think all of us as care navigators, all of us are patients, would prefer a preemptive, early diagnosis, predictive diagnosis, wellness-focused healthcare system that leverages the data of the millions of people who have come before us so that our care journeys are more predicted and the potholes are avoided. But if we want to do that, and imagine it's going to be fueled by machine learning and a machine learning life cycle, what are some of the things we need to do? Well, first, I think all would agree that it starts with data and multimodal data. And so that means your electronic health record is just one piece of what it is we need. And the electronic health record has structured data like problems and meds and labs, and unstructured data like notes and reports. It has telemetry, EKGs, rhythm strips of all kinds, even wearable data. It has images. It has omics. And as we heard in the introduction from Curt, it has digital pathology. So even tissue could be 3D or could be scan slides. So if we're going to develop these models that are going to give us that predictive, preemptive, wellness-focused care, how are we going to organize the data? I would argue, this may sound controversial to some of you, that the electronic health record is not the correct organizing principle for multimodal longitudinal data and model creation. Again, right or wrong, and I told Natalie specifically, this is not to tell you, oh, Mayo has figured it all out and here's Mayo's approach, but I'll just tell you from experience, if you're going to gather a multimodal data store, the EHR is one component of it. And that's great. I mean, there's data that we record as part of a process of care from a regulatory compliance and billing perspective. But there is also a wealth of exposome data, where you live, how you live, what you eat. And some of this data is going to be patient reported outcomes or the digital exhaust from the devices that we carry. Some of it will be submitted from the sensors in our homes or the sensors that we wear. Some of it will be unique image data. And an interesting challenge is a lot of these novel data sources don't quite yet have data standards. So all of us are going to be working on how do you ingest, organize, build ontologies for all of this multimodal data. What Mayo chose to do starting about 5 years ago is we created something called the Universal Data Platform, the UDP, creating an OMOP schema. And that OMOP schema was abstracted from the electronic health record and populated by the electronic health record, but also had the ability to ingest all of our images, digital pathology, omics, telemetry, and patient-reported outcomes or patient-reported healthcare data. So at the moment, what we have is 10 million longitudinal birth-to-death multimodal records at Mayo. And our notion was sometimes if you're a model developer, if you're inside the organization, there's one set of processes. If you're outside the organization, it can be really quite hard. Industrial collaborations can take a long time, often are ad hoc. So could we imagine how to create a platform a platform where all of the technical components were prearranged, the templated legal agreements were frictionless, and you could go from taking a random industrial partner to giving them full access to 10 million records of multimodal data in 2 weeks with minimal lawyering. And I realize lawyering, not exactly a verb, but I think you know what I mean. So we did that. And this was hard, right? January through April of 2020, we de-identified all of the structured data of 10 million patients. And, you know, that's not so hard. You remove the 18 HIPAA identifiers and it's structured data, relatively predictable. So you could say it's pretty hard to re-identify. The harder thing was from April through August of 2020, we de-identified the entire unstructured text of 10 million patients. And we had to do that by using natural language processing and ML methods to look for things like proper nouns, job roles, familial relationships, or geographies, right? So you could imagine that even though HIPAA tells us 18 identifiers have to be redacted, if there was a, say, free text record that said, this former governor of New York, well, that's not exactly de-identified, is it? Because the search space for former governors of New York is pretty small. So you'd have to do what we call hiding in plain sight. You'd identify that job role and that geography, and you might say, this former congressperson from West Virginia, right? Making it harder to re-identify the underlying record. And so then we had to march through images. Now images, that was its own special issue because images sometimes have embossed nameplates. You might have a name or medical record number or annotation of some kind. You have to do OCR and remove that. Or maybe it's a CT or MRI of the head. And you recognize that using Terra Recon or other 3D reconstructive methods, you can take the thin slices of a CT or MRI, do a 3D reconstruction of face and facial recognition. And what we found is 27% of the time we could re-identify a person from a CT or MRI that had been de-identified. So we did 0 voxel heights on the skin layers of images of the head so that you would again make the re-identification process much harder. In effect, there's no skin layer to reconstruct. And similarly, we had to march through the telemetry, we had to march through digital pathology, redacting any annotations or labels on slides and that kind of thing. So that's great. We now have this de-identified cloud-hosted data set for model development for 73,000 employees of Mayo Clinic and over 60 collaborators in academia and industry across the world. But is that sufficient? Mayo has wonderful patients who come to our destination medical centers in Minnesota, Arizona, and Florida. Suppose we create a model, and of course I'm making this up, using 5 million Scandinavian Lutherans from Minnesota, and then we deploy it in Salt Lake City. Is it going to work? Is it going to be fair, unbiased, effective? Do we know? So we need a much greater set of data than any one institution can provide. And that means we'll call it a distributed data network where Stanford and UC and Duke and Hopkins and Intermountain all work together in a virtuous fashion to provide the underlying data that is necessary for the development of models and the validation of models and the local tuning of models and the monitoring of models. But again, here's a challenge. Sometimes, you know, Curt and I have been in this business for over 40 years. Sometimes the issue is technology. Sometimes the issue is policy. But more often the issue is psychiatry. And that means, oh, well, I don't want to share my data, or I don't want to share my intellectual property. Somebody could scoop my research. Oh, maybe I won't get my grant. Or maybe there is a privacy or regulatory threat if I make my data available, even in a de-identified fashion in a closed cloud container. So how does one overcome that? So you can imagine a future of a distributed data network where each organization has control of its data destiny. yes, it's put in a standard form, standard schema, standard ontology, but there are IP protecting and privacy protecting ways where organizations can bring algorithms and data together without having to disclose either across the firewall. And we've worked with a number of collaborators on such technologies and policies. We've even worked across geographies. So we've worked with Israel, we've worked with Europe, we're about to work with Canada, so that there is a mechanism of organizations working together for algorithm development and testing. So that's an interesting issue that, okay, we're gonna, each of us create multimodal data stores. They will have what I call depth, different kinds of data types. They will have breadth, numbers of patients, and they will have spread, the heterogeneity of the patients that you're including in these data sets. And we're all going to work together on creating these models and validating these models and then getting those models deployed. But again, just having data is not sufficient. As we have many of us, Nigam Shah at Stanford, Atul Butte at UC, Mayo, Hopkins, Duke, Google, Microsoft, we've started to look at what are the ways in which we introduce bias into the algorithms we create. So, getting around data bias, okay, we can do that with a distributed data network, but model bias, how do we create the model? What were its inputs? What is its outputs? How are we deploying it? How is it used and applied? I mean, there are a number of other things that we need to pay attention to if we want fair and equitable and transparent use of machine learning that's a bit more frictionless. To do that requires more than any single academic institution or company coming together. So a year ago, a number of us created something called the Coalition for Health AI, abbreviated as CHAI. You'll find it at coalitionforhealthai.org. Tomorrow at 2 o'clock, we will be releasing our first set of guidelines and guardrails for the country, co-authored by Stanford, UC, Duke, Hopkins, Mayo, Google, Microsoft, FDA, HHS, a whole variety, over 60 organizations. What are some of the characteristics of this document you'll see tomorrow? Well, so the first is that we define such things as, well, what is bias and how do you measure it? What is equity? What is fairness? What is testability? What is usability, safety, transparency, and reliability? And then what are the metrics that one comes up with so that you can enumerate each of those characteristics about any given model? So that's good, right? It's a blueprint, you'll see it tomorrow, which looks at those kinds of definitions, the existent work that has been done, and Stanford and Hopkins and Duke and Mayo contributed all their existent IP in this regard. So you'll find all those references in the blueprint. But again, then there's more that we are going to need. So, okay, we'll define what are the metrics to measure our algorithms in all these various different dimensions. And we'll work on a national or nationwide distributed data network. So there's model development and validation across deep and broad and heterogeneous data. That's all good. But there's also going to need to be, if we're going to reduce the friction to deployment, there's going to be a nationwide registry. This is likely something created through public-private partnership. This would be a guess, where we enumerate all the metadata characteristics of every model that is created and make that publicly available. Think of it about like a clinicaltrials.gov, but for ML models. And why do I tell you that? So let me give you a case example. My mother, 80 years old, recently had a brain abscess. That brain abscess was treated. She had a number of complications along the way. Part of her complications, she had a bleed. About half her blood volume bled into her iliopsoas muscle on the right. And she developed AFib. So interesting question. 80-year-old female, status post brain abscess, now in AFib, having had a recent bleed. Do you anticoagulate her? Well, I don't know. I was taught in the 1980s, when I was in medical school, that anticoagulation should not be done for patients with a recent bleed. Oh, but wait, she's got AFib and there's a chance of stroke. What is the greater good? Anticoagulation or not anticoagulation? The only way we're going to be able to answer that is by looking at millions of patients like my mom and be able to say, oh, well, I'll make this up. There's a 64% chance of rebleed and a 36% chance of stroke. Probably odds are you shouldn't anticoagulate because the drug or treatment is worse than the potential for future disease. And so you can imagine if we had this national registry of algorithms and the performance of those algorithms, that you would be able to say, oh, I'm looking for that algorithm that works on 80-year-old Eastern Europeans and has something to do with bleeding risk or AFib. And that could be an algorithm produced by Hopkins or Intermountain or Stanford or Mayo. You pull down into your workflow as you need it that the various kinds of tooling that is going to give you the advice that is going to fundamentally change the course of patient treatment, avoiding some of the potholes that might come from complications. So this report, yes, it enumerates all the measures and metrics of all the fairness and usability. It describes the need for a national distributed data network of virtuous folks coming together of breadth, depth, and spread. It also describes the need for a national registry of ML performance that then can create transparency and enablement for providers and payers and pharma and policymakers. And some of the interesting work we'll all have to do is ask the question, if there is an algorithm useful for the person in front of me, how do we deliver it into workflow? I can tell you that more alerts and reminders in Epic is probably not going to make you popular. So how you intervene in such a way that a clinician or a care navigator or manager is given that just-in-time advice to close the loop, do no harm, and create benefit without creating burden? I don't know that that's a solved problem. Could it be fire CDS hooks? Could it be a smart on fire app adjunctive to the EHR? How are we going to do this? Because as I say, alerts, reminders inside an EHR or loading a new app or having to do a new website, these are probably not things that our clinicians are going to want to do so much. Well, okay, so imagine that we've got to a point where we've got all these wonderful algorithms and metadata about them and a mechanism for delivering them in workflow. How do we ensure over time that they stay useful? And let me give you a quick example. So imagine we all work together to create the world's best telemedicine triage algorithm in January of 2020. And then we deployed that telemedicine algorithm in April of 2020. I think we could easily argue the number of patients using telemedicine in January of 2020, 3%, was a little different than the number of patients using telemedicine in April, 95%. And so you had data shift, and therefore the models need to be recomputed. And so I think what we're going to also have to see is ongoing monitoring systems that examine the effectiveness of the models we deploy, their impact. Call it almost a knowledge engine of sorts. So you're going to need to be able to not only know what was the model transparency and how it was developed on what data and where it's useful, but how useful has it recently been? Did you start with an AUC of 0.93 and it's now got an AUC of 0.33, right? And that's kind of exhaust, if you will, that we're going to have to gather from our use of algorithms in continuous monitoring, tuning, and improvement as these algorithms go forward. And there are several other considerations. We all know social determinants of health are important. There are some challenges with social determinants of health. If you look at the data quality in our EHRs or in our registries of social determinants of health, you'll find sometimes a lot of data sparsity. That is, not all the records have social determinants of health. We have to be a little careful. Recently, Mayo was given access to a database with 31 billion encounters, and only 15 billion of those had social determinants of health. And so the question is, maybe it was those of lower income, lower education that didn't report social determinants of health. So even using such a database, even though 15 or 16 billion sounds like a lot of data, may itself be so flawed and biased. You should be very careful about social determinants of health recorded sparsely. What Mayo has done is created something called the Houses Index. And we've done this for 44 states so far. We can take your latitude and your longitude, and from that, understand, well, where's the nearest grocery store, primary care office, access to colonoscopy, public transportation, crime, education, Superfund site. And we can infer social determinants of health from that geography and use that as a kind of proxy for self-reported data, and do our model creation, validation, and tuning with this Houses Index. And I think Natalie would probably appreciate one example. We recently used the Houses Index in a pediatric asthma commercially available algorithm. And what did we find? That if you stratify your population into quartiles, and you look at those with the greatest income and social challenges, the algorithm, commercially available pediatric asthma exacerbation forecasting algorithm, it's horrible, horrible. And so, well, maybe why? Well, maybe those in the lowest quartile are next to more air pollution, or maybe they don't dust as frequently. Maybe they didn't refill their meds, seek primary and preventative care. The point being is that you're going to have to keep in mind social determinants of health as we do this virtuous ML ecosystem deployment. And there's other things that we need to keep in mind, such as the digital divide. Some years ago, a large company in California, I won't mention which, sent a number of engineers to Boston. And these engineers wanted to understand the workflow of Medicaid clinics and how we serve the underserved. These wonderful engineers, all under 30, went to an elderly gentleman in this Medicaid clinic and said, "What's your favorite wearable?" And that person said, "Socks." Right, so if we're going to build this ecosystem, but it's going to depend upon users having an iPhone 14 and an Apple Watch Series 7, we're going to create a worse digital divide than we have now. So we also have to think of, as we deploy these various solutions, is it that we're using care navigators or care managers, called digital assistants, if you will, that help an individual patient get the best care. But maybe if that patient doesn't have technical literacy or comfort or trust, they're helped by somebody who gets the right tool to the right patient in the right context. Always need to keep these kinds of things in mind. So what I hope we can do together, all of us, is transcend any institutional affiliation, any geographic or regulatory affiliation, and work together on solving a number of these problems. I mean, you've heard me enumerate some of the white space issues of defining what is testability, usability, fairness, bias, ethics, and measuring it, not just once, but in a continuous way, and transmitting that information broadly across all the stakeholders, and incorporating algorithms from anyone, anywhere. Of course, there'll be value creation, I imagine. So that is when you pull down an algorithm and use it. I mean, somebody could pay for that, understood. But to make it more automatic than it is today, because no clinician, they're overwhelmed today, has the time to go look up the AUC of an algorithm and decide which one to use. It has to be presented in a workflow that is more frictionless than clicking on a website or launching an app. So there you go. Hopefully that outlines where we are, where we're going, and maybe just conclude with the statement, if we looked at Meissen and our experience in the late 70s and the early 80s, and the optimism that we felt, why in 2022 haven't we finished all the things that I have enumerated? Well, I will tell you that, as you heard from Curt, I did serve in the Bush and the Obama administrations, overseeing a variety of our standards and the high-tech regulations and such. Don Berwick, who founded the Institute for Healthcare Improvement, would tell you sometimes we engineer the exact result we get. We have focused on digitizing healthcare, and we have done that. But I would argue we've lost the hearts and minds of our clinicians along the way. So we did important foundational work, but now it's time to give our clinicians something back, leveraging the data they've diligently input to give them the advice, the wisdom to change the way patients receive care, to be more preventative and proactive, to reduce the burden on our clinicians. And I believe the next 6 quarters are the time to do that. So thanks very much. And hey, Natalie, want to turn it back to you.
Wonderful. Thank you, John, so much for such an invigorating talk. And again, for the audience, I'm Natalie Pagler. I'm the Chief Medical Information Officer at Stanford Children's Health, and I'm really excited to get some opportunity to chat with you, John. For the audience, just a reminder that there is the Slido tab where you can add questions for John and or upvote some of the questions that have already been put in there. And we do have several thought-provoking questions from the audience already, John. But I'm going to start off with one just to get us going, and then we'll jump to some of those. You have such a unique perspective, given your long and varied career in healthcare and your vantage point in building and vetting all of these tools for the Mayo Clinic Platform. I'm sure the audience would love to hear a little bit about your predictions for what healthcare might look like in 5 years from now.
Well, sure. So, Natalie, so you and I imagine, are contacted almost every day by someone who says, oh, my buddy, my son, my mom has XYZ. Who do I see? What could it be? Will there be a good outcome? And so we end up being these odd kind of care traffic controllers for hundreds of people. And that shouldn't be, right? So I am looking at startup companies, I'm looking at academic organizations creating these mechanisms to say, well, 1 million patients like you went on this journey, call it Ways for Healthcare. And they got to where they needed to be in relatively short time with relatively few complications, and there were no accidents along the journey. So I guess my personal prediction will be, we have to take what is our disconnected healthcare system and somehow thread it into this world of emerging algorithms so that individual patients can navigate it without having to consult Natalie or John. That's my hope.
I love it. Yes, definitely know that feeling, and it would be great to have something a little more solid to turn to when we get asked those questions. So let's turn to a few of the questions from the audience. One of the ones that's getting some upvotes is just about the health IT industry and EHRs, and the fact that many people consider health IT and EHRs to be behind other industries. Do you have a feeling, or do you have thoughts on why health IT might be considered behind other non-healthcare industries?
So I addressed this a tiny bit in my remarks by saying, we engineered exactly the result we got. And for those of you who weren't there at the time, let me just tell you how it went. So we did a needs analysis, good engineering thing to do, right? And the FDA said, oh, medical device safety, very important. So what we need is a universal device identifier. We need to be able to track devices over time. Okay, great. CDC said, oh, biosurveillance, emerging infections. CMS said quality. In fact, we need 15 quality measures. Well, before you know it, all of the requirements analysis across all the government agencies required 140 data elements to be captured at every encounter. And none of these were for the benefit of the clinician. None of it eased the navigation or the care path. And then we instantiated those in certification requirements and all the whole stimulus program and all the rest. So, okay, again, we got to digital, records, but it wasn't focused on usability or patient or provider joy. So, sometimes, I guess Winston Churchill taught us, Americans always do the right thing after they've tried everything else. So sometimes you actually have to fail in order to see the path forward. And I would argue we actually are starting to see, especially in the startup community, those who recognize the EHRs have failed to deliver on the promise of usability and burden reduction. So they need to be wrapped with new systems that help us reduce the overwhelming administrative cost of capturing the data.
Yeah, absolutely. And I think your point about, all of the regulatory requirements that we've built in for documentation, continues to be an issue. And I think every time there's a new issue, we just say, well, just add a layer of documentation into the EHR, which may not correlate with what's actually happening in the healthcare system itself. And in fact, the increased documentation requirements may take people away from the bedside and doing the right thing. So it's an ongoing challenge for sure. Let's transition a little bit. People want to hear more about the distributed data networks that you were talking about. How exactly will those be set up? How do we address the challenges that privacy pose? You've spoken a lot to some of the anonymization efforts, but can you provide a little more detail about how these distributed networks might be set up?
Sure. And so here's the good news. Remember, Natalie, I don't have every right answer. And in fact, as I've looked at the industry, there are probably 5 different approaches that one could use, from federated to distributed to centralized to curated and on and on. But what at least Mayo has chosen to pursue is to say, hey, organization, do you want to join a virtuous ecosystem where we can do model development and validation against each other? Okay, we'll all agree on a schema, and you will move the corpus of data from all your data sources into a longitudinal schema organized by person, not encounter, right? Because it's by person, it's their experience over life. And with the right, ontologies, it's more or less comparable across organizations. It will be de-identified using some standard methods that make re-identification quite hard. But then there may need to be technologies, and again, I'm not endorsing any product or service here, that enable an algorithm held by one party to interact with data held by another party without sharing the data or the algorithm bidirectionally. And again, there are multiple approaches to this. Some are cryptographic. Some are using secure computing enclaves. NVIDIA and Microsoft and others have created that. Right? There are spin-outs in Northern California, like Beekeeper, where Mike Bloom is trying to figure out ways in which these kinds of things are happening. Or Verily has created a mechanism called Terra, where each of us is given a secure container. We place our data in that secure container, and algorithms can go across each container, but no container can see the other container. Right. So I think, yeah, Mayo will start with its approach of DID, standard schema, and mechanisms of privacy and IP protection between entities. But Verily and Beekeeper and others will continue to try. And it may be that multiple models will go forward depending on the domain and the use case. And that's okay.
Great. Thanks. Well, just to kind of dig on that one a little bit more, the blockchain buzzword came up, and I know that you served as the editor-in-chief for Blockchain in Healthcare Today, and you just mentioned, cryptographic approaches. So what are your feelings for blockchain technology in this space, and how may it play a role in some of this work?
Well, you ask a fascinating question. And let me give you my honest opinion, having worked in blockchain in a variety of ways over the last 5 years. Paul Krugman, a columnist for the New York Times, wrote a rather brilliant piece over the weekend, which was effectively said there is no good use for blockchain for any use case by anyone, anywhere, at any time. Now, that may be slightly harsh. He was writing in the context of FTX, you can guess. So where have I used blockchain practically? I'll give you one use case, because there aren't a whole lot of them, but there are some. About 5 years ago, the Bill and Melinda Gates Foundation asked, could you imagine empowering patients in South Africa by giving them access to all their HIV-related laboratory results, CD4, viral load, variety of things? Well, it turns out that in South Africa, there's only one lab system for the country, the National Laboratory System, NHLS. Well, it's run by the government. Well, Natalie, do you trust the government? There are some people who don't trust the government, wherever the government might be. So we asked the question, what if, as data was generated off the analyzer, you created a hash and you just stored the hash of the data as it came off the analyzer, and when a patient retrieved all their data, you could show them a little lock that said, oh yeah, actually all the hashes of all your data match what we now have delivered to you. You can trust it. So I think blockchain is kind of good for one thing, and that is the reassurance that data has not been deleted or modified. But it is not a database. It is not a health information exchange. It is not good for analytics. It is not good for large data elements. It's just good for metadata and non-repudiatability. And so focus on the very narrow and ask yourself, do you really need blockchain?
Very helpful, thank you. All right, continuing to move on, we've got a question from the audience about how to integrate the efforts of the federal government through AI initiatives being taken with the VA healthcare system and the public sector.
Sure. So my friend, and I'm sure many of you know, Mickey Tripathi, our national coordinator, has been assigned by Secretary Becerra to be the nation's navigator for all things healthcare AI. Now, that doesn't mean that ONC is going to promulgate all the regulations, but it does mean that ONC is going to coordinate the efforts of FDA, CMS, VA. So I think you can trust that Mickey is going to do a pretty good job here of making sure that there's regulatory consistency. And although I have no inside information, none, I think you'll see in the next quarter to two a variety of notices of proposed rulemaking on a variety of topics, from 42 CFR Part 2 and data sharing to when, software as a medical device rules need to get applied, to where there are opportunities for us to get more and more of these algorithms into production. So I think we look to ONC to help us navigate across these federal agencies.
Wonderful. Okay, we'll jump from federal agencies back to the industry. There's a question about how the private healthcare sector can get involved and what role might they play with the academic network, the Mayo platform that you're talking about.
Sure. So there's two kinds of ways to validate an algorithm. One would be it's mathematics, right? Can we say, oh, we're going to subgroup this by age or gender or whatever other variables, look at AUCs and performance. But how does that actually work in practice, right? So I'm going to guess, again, this is just a bit of a guess. It's going to be the community health settings of this country, not just the academic medical centers, that are going to report on how these algorithms deployed in the field are really working or not. This is the concept that I mentioned about digital exhaust, or building a knowledge engine that is gathering I deployed this algorithm, it made this recommendation. Here's how it actually worked. It was good or bad. We're not going to know that unless we get this stuff widely deployed in a test harness across our provider organizations, especially smaller non-academic provider organizations.
Great, and that actually touches a little bit on one of the other questions, which is about what are the metrics for success? Is AUC really the best metric? How are we really going to capture whether an algorithm is beneficial or not?
Right, so AUC should be a metric. I think that's true, right? How when we developed this thing did it seem to work? But this is what I was getting at, exactly right. Well, did the patient get better? Did the patient have less complications? I mean, a quick example for you. Mayo launched something called Advanced Care in the Home, where we're delivering high acuity hospital care in living rooms nationwide. We've treated about 12,000 patients. And in deploying algorithms and dashboards and new workflows, we've reduced readmission rates 25%. We've eliminated hospital-acquired infections and falls. And the net promoter score from patients is 97%. Well, that's a pretty interesting way of looking at a technological intervention. The patients love it and they're safer and it costs less. Well, that seems pretty good.
Yeah, absolutely. I mean, there's so much, the AUC is a number for the algorithm, but really what we care about is where, what are we going to do? How are we going to act on those algorithms? And there's so much that comes into the interplay between the intervention and the threshold that we're using to act. So yeah, complicated but important questions. Let me jump to a little bit, we have so many people in the audience that are, either early on in AI or students in AI. Given your vantage point in building and embedding these tools for the Mayo Clinic and your long healthcare experience, what advice do you have for trainees and early career researchers in healthcare AI? What are the big problems that they should focus on going after?
Well, so a couple of thoughts. So remember, all this is math, not magic, right? So Natalie, I just give you this very funny example. When I was a resident in emergency medicine at UCLA, we developed an algorithm. Wasn't really an algorithm, but we said if a patient after a trauma came in with crossed legs, they would do fine. And when you think about it, that actually could have been correlation, not causality, because if you could cross your legs, it meant you probably had your sensory motor pathways intact, right? And so I think one of the areas to look at as you do these models is, well, we won't always have explainability, but at least can we choose a reasonable number of inputs and outputs so that it sort of makes sense? Can we study causality, not correlation? Again, I think really important that your trainees have a sense of the medical domain, and so they don't create models that have wonderful performance characteristics but are functionally useless. And let me give you an example there. So an engineer recently working on Mayo de-identified data said, oh my God, I've got the most incredible algorithm, has an AUC of 0.99, you need to deploy it immediately. The algorithms assessed an input of whether a patient got high dose morphine, and then they had a hospital readmission. Well, and then the engineer said, oh, by the way, what's a palliative care unit? Right? So please look at the explainability, the causality, the utility of these things as you deploy them. And let us all try to work together to create highly repeatable processes so that an organization like Stanford spins out multiple companies. Mayo would be thrilled to use Stanford IP. But there's no way that that's so easy today. And I'm not suggesting an app store exactly. I mean, that's probably the wrong analogy. But there should be, as you heard me describe, if we all work together in publishing our work into a registry and make a standard process available for pulling an algorithm into workflow that is likely to be useful for the patient in front of me, we'll get the benefits of ML with safety and quality and at least less friction than we have today. So those are all great areas to work on.
That's really helpful. It does lead to the question of, what the incentives. And there are folks asking about, why would anyone give away algorithms free? How is all this work going to be paid for? Where are the financial incentives coming from? How can we transcend the greed of my data? Do you have thoughts around the financial approaches here or the financial incentives?
Well, sure. So again, I don't have all the answers, but I'll tell you one of the things that Mayo has done. Sometimes what Mayo will do, because we have an accelerator, and I'm sure you have an accelerator, we'll say, hey, innovative company, how about this? Let's co-develop some really cool stuff together in exchange for 1% of your equity or some number, right? So that is, oh, you're actually all working together collaboratively, and the currency is the equity should the thing actually work. Okay, well, that's interesting. We also certainly strongly believe in revenue sharing. So imagine, I'm again making this up. Mayo has an amazing algorithm, and it's going to work together with Stanford to validate it. And Mayo is going to agree to give 10% of any revenues back to Stanford for all its work validating, right? So these notions of revenue share when something works or equity growth, those all certainly work. And I guess, sure. And there's also licensing that sometimes happens. So as Mayo has progressed through this journey, we've recognized it's not going to be one size fits all or a single model, but there'll be multiple models to ensure the incentives are aligned.
And I mean, so the incentives are aligned for algorithms. I think there's also multiple questions coming up about how about the data sharing and how do we get to equitable data sharing? How do we align those incentives as well? I think you've talked about some of that with the work that you're doing with Mayo.
Yeah. But so, again, I'm not going to criticize anyone's approach, but in my experience in doing this for 40 years, if I say, hey, Natalie, could you just send me all of Stanford's data? Trust me, that never, ever works. As opposed to I say, hey, Natalie, I've got this algorithm. I'd love to send it across your firewall, and you tell me it's AUC so in your particular population, and in return, there'll be some value created. But I never see your data at all. Oh, well, hey, happy to do that. So I think, again, you have to be a little careful on the policy and the psychiatry side that you're not demanding risk and trust, but you could still work together pretty well as long as you architect this thing properly.
Great. The questions keep rolling in. So now I've got a question about how to overcome data paucity, and the author asks, do you anticipate that the future combo would be something like federated learning plus digital twins plus data distributed networks to overcome data paucity? Give thoughts on that challenge.
I mean, there's some really interesting challenges here. And when I talk to some colleagues at Change Healthcare, again, not endorsing any product or service here, they said, they've looked at this problem in two ways. Sometimes it's the same data type and that it is just recorded in 20 different places. And that's one kind of mathematical problem. We're going to take the images from Stanford, the images from UC, the images from Mayo. But sometimes it's that there's different modes of data stored in different locations. Again, making this up. Mayo has the longitudinal record of 10 million people, but it doesn't have their grocery shopping list history. Oh, but Kroger has their grocery shopping list history. And then that's a little different problem of bringing different data types across entities together, because it requires identity resolution rather than just population health and that kind of thing. So I think we're going to have to work on both problems. One of the things that gives me hope, and it's early, but with the interoperability rule, the information blocking rule, there is this notion of patients as their own data stewards. And whether it's the patients or a proxy that the patient assigns, but the notion that a patient can take part in bringing these data types together for the benefit of all. And that's pretty exciting. My father, who died 10 years ago, had multiple sclerosis for 23 years. And he told me he would be thrilled to share his phenotype, genotype, and exposome, as well as his experience with every medication he was given, Copaxone and interferon and all the rest, for the benefits of those in the future. So we have to think there may be some patient-mediated data exchange that helps us along this journey too.
Right. Yeah. Well, and again, so you touched already during your talk on some of the issues with the digital divide. And the data paucity and where our data comes from can really affect the types of data that we're getting. There are more questions coming up about how do we eliminate biases in current data sets. And I know you've recently blogged on the algorithmically underserved. How do we ensure that these algorithms are bias free? Can you speak a little bit more to some of the approaches that we need to take on that?
Right, and so in that blog, what I was referring to is there are multiple kinds of problems to solve, right? So some may very well be, oh, I'm in a rural area and my doctor doesn't have an EHR. So I'm just not represented at all. So then the question is, well, are there other proxies for the data that would have been recorded electronically? Could there be data from your phone, data from your home, that kind of thing that one might use? Or if there are small subpopulations, and the example I used in the blog is, well, hey, we've developed an algorithm. It doesn't work on American Samoans. Well, how do you get more data about American Samoans? And well, that's a slightly different problem. So I think, again, we have to be a little careful here, is look at, is the issue data quality, data quantity, subgrouping analysis, a lack of capture, and there are going to be different solutions. The houses algorithm, which I mentioned, was actually a proxy for data paucity, because although you may not report your social determinants of health, we know a little bit about inferred social determinants of health from the place you live. And that's one answer.
Great. There was you touched on, rural providers who may not have an EHR. There was a question from the audience about, should the government provide free EHRs to everyone to help with the data solution? Clearly, we've had high tech and lots of regulatory initiatives to try to influence EHR implementation, but do you have other thoughts on how the government should be funding or supporting more distributed health information systems?
That's a really interesting question. And you again wonder, this is just speculation. Could there be an economic model where we don't sell data ever, ever, ever? We think selling data is very, very bad. But a rural provider who is helping capture knowledge, where that knowledge is leveraged to validate or produce algorithms, could provide something of value without actually parting with the data itself, that could be then used to subsidize the tools they're given. So I do think this notion of sort of generalizable tools that are made available in a rational economic model certainly is worth pursuing.
Wonderful. Lots of conversations to have there, and I probably need to loop back with Mickey Tripathy to explore the options there. All right. Well, let me close out with one last question. I'm the program director for the Clinical Informatics Fellowship, which is a 2-year fellowship for physicians who have already completed their clinical training. You obviously are a physician who's had a lot of interesting background in technology that you've been able to bring together into an incredibly successful career. There's a question from the audience about, do we see demands for physicians with technical knowledge? So would love to hear your thoughts on the future workforce and who do we need to bring in to continue to move healthcare forward in the right direction?
So I'm going to answer that in a slightly quizzical way, which is, again, I've been at this for 40 years, and by no means is the 2022 environment like the late 70s environment. But I will tell you, it has always worked for me to work at the intersection of disciplines, right? And that is, so I have biomedical engineering and mechanical engineering training. And sometimes I'll say, oh, well, here's a robotic algorithm for an integrated proportional derivative controller. And, to be honest, that actually solves this kidney problem pretty well. Yep. Right? So that is, make sure you are embracing multiple disciplines. It will not only give you novel solutions, but as an academic, it will actually give you rapid promotion, because you'll be working in areas that no one else is working. And they say, that's amazing and important work. So study work at the margins and the intersection.
Absolutely agree. And I think, we've just seen such huge leaps forward when we bring cross disciplines together. Do you have advice either for trainees, like how do they successfully do that? Or, how can we create those conversations within our healthcare systems to make sure that we are bringing in different disciplines to this work?
So again, I'll make this very personal. So what is my role as a 60-year-old person with 40 years of experience? Building coalitions, partnerships, bringing non-obvious parties together to brainstorm. And it's a peculiar thing, because sometimes if you look at our academic training, it's, oh, my lab and my paper and my grant and that kind of thing. And what I figured out is it's bigger than us. And it's, if nothing else, if I spend the next 20 years bringing these people together from all these various disciplines and trying to create some magic, sometimes it works, sometimes it doesn't, but it's a very fruitful thing to do.
Absolutely. Great words to end on. Well, John, thank you so much for this wonderful conversation and your insights as always. It's been incredibly stimulating and you've given us a lot to think about. We really appreciate your time this morning.
Well, and remember, I'm a Stanford guy by background, so anything I can do to help, I'm always here.
We love it, and you're welcome back anytime. Thank you so much. All right, with that, I'm going to turn things over to our inaugural Director of Education at the Stanford Institute for Human-Centered AI, John Robichaud, to introduce our next speaker. Thank you all.
Thank you, John, Natalie, and Curt, for an extraordinary kickoff to this year's conference. My name is John Robichaud. I'm Director of Education here at the Stanford University Institute for Human-Centered Artificial Intelligence, or HAI. I'm one of the co-hosts for this year's conference and one of the co-founders of the Stanford AI and Health Conference. It's my pleasure to be able to join my voice to the many others in welcoming you to this year's annual event. Once again this year, we're thrilled to be able to welcome thousands of executives, policymakers, researchers, faculty, students, practitioners to this year's conference to be in conversation with hundreds of faculty from Stanford and other researchers from around the world to tackle issues at this important intersection of AI and health at this important moment in history. You honor us with your presence, and we hope that this conference's conversations and presentations will be ones to inspire you to think about your place within AI and health, both now and in the future, and that the conversations and networking opportunities that this conference provides, even in the online environment, will be ones that you'll take with you, again, not just in the next year before next year's conference, but well into the future. Indeed, we hope that this conference is a highlight of your year and your work in this space, and we're thrilled that you have joined us and honor us with your presence. Let me also take a moment to thank the many hundreds of people who are working behind the scenes to make this conference possible. Both the staff, faculty, staff, and students at HAI and our partner entities at the School of Medicine and around the university have worked tirelessly for many months to make this day and this conference possible. We don't all get to know every one of their names. We don't get to see them often throughout this conference, but their behind the scenes work is the work that allows us to be here both live during these 2 days and in the online asynchronous world in the months ahead. So no matter how it is that you come to us today, just know that there are many people who helped get you here, and we're thrilled and we're honored for the work that they do to benefit all of us in this conference. So thank you. Finally, it's my privilege to be able to introduce this year's second keynote speaker, Dr. Pricilla Chan. As many of you, of course, know, Dr. Chan is a co-founder and co-CEO of the Chan Zuckerberg Initiative. She's a pediatrician and a teacher, and Priscilla's work with patients and students in communities across the Bay Area have informed her desire to make learning more personalized, to find new paths to manage and cure disease, and expand opportunity for many more people. She's also the founder of the Primary School, which integrates health and education and serves families and children in the East Palo Alto area and the Bellhaven neighborhood in Menlo Park, California, both nearby neighborhoods. Priscilla earned her BA in biology at Harvard University and her MD at the University of California, San Francisco, UCSF, where she also completed her pediatrics training in the UCSF Plus Pediatrics Residency Program. Dr. Chan's remarks are pre-recorded. We thank her for the time that she took to be with us in preparing these remarks and recording them for us. And we look forward to the words that she's going to share. We hope you enjoy. Without further ado, I present to you Dr. Pricilla Chan.
Hello, everyone, and thank you to Stanford HAI, AIMI, and Stanford CME for bringing this group together. I am thrilled to join you today, mainly because I'm excited about the intersection of health and AI. But I also feel like this is my big break. I got rejected from Stanford. In fact, I got rejected twice, first for college and then for medical school. I would like to say that it's all water under the bridge now, but most of you are academics and you know exactly what I'm feeling. But in all seriousness, I am really thrilled. Conferences like this attract such a special group of people. There are students in the audience, researchers, people building new companies, new policy frameworks, new technologies. Everyone here has their own story, but we are all driven by this opportunity to create something new. And really, this belief that by exploring new horizons in technology and health, learning new things and working together, we really can build a better future. We're here today because we believe that AI has that potential, especially for human health. I'm a pediatrician. I used to see patients who had rare genetic disorders, and it was heartbreaking. Very often, there was little we could do to help because we knew so little about the underlying disease. It was clear to me then, and even clearer now, that AI will help change that. We'll use it to make sense of that ocean of genomic and proteomic data to understand how cells function when they're healthy and what goes wrong when we're sick. I've learned even more from my friend Feifei Li, who does groundbreaking work here at Stanford. She helped open my eyes to the ways that AI can empower those of us working in healthcare. Take the problem of hospital-acquired infections. In the US, they kill more people than car accidents. And in many cases, improper hand washing is to blame. So Feifei started asking questions. What if we used AI to monitor the hand washing stations in the intensive care unit? What if a simple automated alert, scrub a little longer, could save lives? Even better, what if nurses in the ICU could free up more of their time for patient care by delegating some of their work to AI assistants? The healthcare system is full of these opportunities, but right now, we aren't doing everything we can to realize them. My perspective on science and AI reflects the journey that I've taken to get here. My parents fled the war in Vietnam when they were teenagers. We were one of the first Asian families to settle in the Boston suburbs. We didn't have a lot. Growing up, I wasn't exactly welcomed by the other kids at school, but I still considered myself incredibly lucky. I had some great teachers who really saw me and did everything they could to show me how exciting science could be. That excitement eventually led me to Harvard, where I threw myself into studying neurobiology. I thought I'd finally found my people, and I even got to spend a summer working in a prestigious lab. There I was, happily dissecting mice. The postdoc I worked with noticed how good I was. So he told me, "You have great fine motor skills. Too bad you're a woman, otherwise you'd be a great surgeon." I was crushed. Experiences like that almost pushed me out of science. But in the end, that experience became a fire that fueled me and I pressed on. I went to medical school at UCSF. I completed my residency in pediatrics. And finally, when I was working with kids and talking to their families, I realized what I couldn't see before. Things that set me apart growing up were the same things that were going to make me a good doctor and a good scientist. In the clinic, I could pick up on the subtle signs that a kid wasn't doing well because I'd been that kid. And because I grew up in a family that didn't have much, I could look out for problems that other pediatricians might miss. Not only the physical, but also the emotional. That same phenomenon plays out in scientific research. Very often, it's the scientists who see the world a little differently, who are able to look at a problem in a different way. They're able to see the solution that no one else can. That's why progress depends on bringing people together, not only in research, but specifically in AI, where the applications are inherently interdisciplinary. The potential to save lives and improve lives is nearly limitless. But is the technology actually going to reflect all of us, or just the lucky few who happen to be in the field now? I don't think it's an exaggeration to say that the future of human health depends on the answer to that question. So we have to get it right. We can't settle for AI that doesn't detect melanoma on Black skin. We can't let algorithms train on genomic data that's almost entirely from people of European descent, because that leads us to a future that looks a lot like the past, where diagnostics aren't as accurate for women and people of color, where drugs only work well for some of us, where cutting-edge treatments and tools like personalized medicine and advanced imaging only benefit a tiny fraction of humanity. We have to build something better. And that's why I feel so lucky to share this message with you here today, because we have the chance to make a difference. It's really that thought, that recognition that we have an opportunity and a privilege to change things, that led me and Mark to create our philanthropy, the Chan Zuckerberg Initiative. In 2015, we decided we could use our resources, experiences, and expertise to tackle some of the biggest challenges in biomedicine. A year later, we took on an ambitious mission to support the science and technology that will make it possible to cure, prevent, or manage all diseases by the end of the century. Making progress on that scale will require a more inclusive and collaborative scientific community and more powerful tools that everyone can use. So early on, we established a few core values that would guide all of our work. 1, we democratize access to tools that drive biomedical research. That includes AI. 2, we foster collaboration between diverse groups across career levels and in many disciplines. 3, we center equity in our work and strive to dismantle the systemic barriers that keep so many from contributing to science. 4, we empower the scientific community, from researchers to clinicians to patients. And finally, we support efforts to make that community more open so that everyone can build upon each other's findings. Stanford was one of our first partners to put these values into practice. In 2016, we created the Chan Zuckerberg BioHub in San Francisco. The idea was to bring together scientists and engineers from Stanford, UCSF, and Berkeley, experts in different fields with different backgrounds, and to give them the time and resources to pursue high-risk and high-reward projects. It was, and still is, an unusual model for biomedical research. And the results have blown us away. Take one example. Early on, the BioHub, together with engineers from CZI, built a tool to rapidly process metagenomic sequencing data. It gave researchers actionable information about the pathogens in a sample, information that would help them identify, track, and hopefully stop an outbreak before it becomes an epidemic. We made that software free and open source. One of the pilot projects tracked a deadly meningitis outbreak among children in Bangladesh. The cause, it turned out, was a mosquito-borne chikungunya virus. Now that was a big surprise because chikungunya wasn't known to cause meningitis in children. Armed with that information, officials could launch a mosquito abatement program and stop the spread. That was in 2018. 2 years later, COVID hit. The world suddenly needed the technologies to track a rapidly mutating virus. That was true here in the US, where some of our most vulnerable populations were disproportionately affected by the virus. And it was true in places like Cambodia, where scientists used our tool to confirm the country's very first case of COVID. In each case, our scientists and engineers were there. The BioHub also focuses on what we call quantitative cell science. In a nutshell, that means using advanced methods to see how genes get expressed in individual cells. We map thousands or even millions of those cells, and those maps feed into what we call the Human Cell Atlas, which will reveal how these tissues, organs, and systems work at the molecular level. That is going to transform our understanding of human biology. And for precisely that reason, we're making sure that the data and the tools are open source. And we're funding teams to collect samples from diverse populations. Because if it's really a human cell atlas, then it needs to include all of us. So all of that work at the BioHub is ongoing, and the successes have shaped our approach to accelerating science. One of the key takeaways is that philanthropy can play a key role at the intersection of AI and health. We have the power to convene experts from each of these disciplines and to create unique spaces for collaboration. At CZI, we've brought that model to life. Our work today falls into 3 broad categories. We fund, we build, and we do. The fun part is most straightforward. CZI awards grants to biomedical researchers, many of them early in their careers, working across disciplines who are breaking new ground across science. The build part is about creating next-generation hardware and software tools, then democratizing access to those tools, so they help drive progress across entire fields. Finally, there's the do category. We bring together interdisciplinary teams over long time horizons to do awesome science that can't be done in conventional settings. The BioHub is one example of that. And in September, we created another institute at Harvard. It's called the Kempner Institute for the Study of Natural and Artificial Intelligence. The premise of the Kempner Institute is that biologists and computer scientists have a lot to teach each other. What we learn about the brain, about our natural intelligence, should help us build smarter AI. And on the flip side, AI should help us learn more about the brain. To realize that vision, the Kempner will spur collaboration on an unprecedented scale. Experts in the brain and AI will work side by side. They'll have access to the most advanced computational tools, and they'll have a mandate to pursue grand scientific challenges, much as we do at the San Francisco BioHub. As a physician, my great hope is that we'll learn enough about the brain to understand how we can fix it. Right now, we don't know how problems at the cellular level can lead to severe cognitive disability. But if AI can help us understand the mechanisms at play, we could intervene. We could develop targeted drugs, or even interfaces that fill the gaps in what the brain is able to do. By the same token, the brain can solve so many problems that AI can't. And if we could understand how, we could build tools that are vastly more capable than those we have today. But here's the thing. If you're actually serious about realizing these opportunities, and we are, it's not enough to get all the usual suspects together and just hope for the best. You actually have to bring new people into the field. People who haven't worked in science before, people who don't have experience building AI, people who work in totally different fields, and people who are just starting their careers. And most importantly, people with great ideas. This field is so young. We know almost nothing about how human or artificial intelligence work, much less what they might one day help us achieve. So we have an obligation to gather as many people around the table as possible. And we need everyone to feel like they have a real stake in AI, because pretty soon, all of us will. That's why our investment at the Kempner isn't just a bet on established scientists. It's really a bet on students, undergraduates, grad students, fellows, postdocs, people from different generations and different disciplines, people who might not otherwise have a path into the field. If somebody, really anybody within the Kempner community has a brilliant thought, we want them to have the infrastructure and resources ready to explore it. In that way, we hope to foster a much more diverse generation of leaders in neurobiology and AI. Now, I want to give you a quick preview of one more institute we're building, and then share a couple thoughts on where we hope to go next. Here in the Bay Area, we're getting ready to launch the Chan Zuckerberg Institute for Advanced Biological Imaging. True to its name, the Institute will focus on visualizing the structures and proteins within cells, not on a slide or in a petri dish, but in the living body, down to the atomic scale, in real time. Today, that sounds like science fiction, but electron microscopy has already gotten us much closer than you'd think. And now we're bringing together the teams to push the technology forward. Experts in physics, mathematics, AI, engineering, and science. Within 10 years, we hope to develop the technology to visualize any process in the human body across spatial scales, to see the process of life as it happens. We'll also share tools as we develop them, both by bringing visiting scientists to the Institute and by building software and hardware to reach scientists around the world. AI, in many ways, is the engine that will make all of this progress possible. The kind of research we're talking about, research where you measure the molecular processes in a single cell, or sequence tens of thousands of mRNA molecules in that cell, and then you repeat those measurements across millions or even billions of cells, requires computation that goes far beyond what the human mind can do. You and your work is what helps make sense of this complex, amazing puzzle that is biology. That's why we're so excited about the investments we're making in AI and the work that all of you are doing too, because this is a pivotal moment in human biology. This is the moment when we go beyond studying biomolecules on their own and to start to learn how they interact as a dynamic system. To put a finer point on it, this is the moment when we begin to unlock the mysteries of the cell, how cells function, how they form tissues and organs, how they change over time, and even how they create the moment that you and I are experiencing right now through cognition, learning, and memory. I think it's easy to have the impression that AI is cold and robotic, but really, it's the key to our most human endeavor, the journey to understand who we are. That's why we need everyone in this room, building their tech, sharing their perspectives, making sure that the training data is representative, engineering equity right into the code. That's our commitment at CZI. And if you're hiring a team or running a lab or creating a company, I hope that's one that you share, because the future of AI and health is here. But who makes that future and what it looks like is up to us. Thank you so much.
Thank you, Dr. Chan, for those thoughtful remarks. Before we turn to the start of the concurrent sessions, there's a brief break, as well as a networking opportunity and an opportunity to engage in the online exhibit hall. That's new this year. We know that many of you value those networking opportunities and the exhibit hall opportunities that in-person conferences provide. And so this year we're trialing an expansion of our networking opportunities and for the first time, an online exhibit hall. We'd love for you to take advantage of these and to let us know your feedback about them. We obviously want the conference to be of value to those who attend. We want to provide things that are useful to you. And so very much welcome your feedback on the networking, on the exhibit halls, and the other pieces of the conference, of course, as well. Concurrent sessions will begin as scheduled on time. We hope that you have a wonderful conference and look forward to hearing great things. Have a great conference all.